our one panelist and distinguished guest, welcome today's discussion for leverage of diasporas to sustain and enhance bilateral relationship. The diaspora community plays pivotal role in fostering connection, driving innovation, and contributing to the development of their countries of origin. Today we have a privilege to hear from one of the panelists, Dr. Zelalem, a CEO of People to People. I'll leave the floor to Dr. Zelalem.
Good afternoon. I'll just quickly highlight about global health systems, global health security and the health systems in humanitarian crisis situations. Global health security, it serves as a catalyst for progress towards vision of attaining a world safe and secure from global health threats posed by infectious diseases. So in this realm, we have key organizations or key players. I'll come back to that. So the key institutions in global health security agenda are World Health Organization, the International Health Regulations of 2005. We have performance of veterinary services, PVS, and we have the World Organization for Animal Health, or OIE. So it is a multi-sectoral engagement. So we have the human and animal health, we have agriculture, we have security, we have finance sectors, we have research, foreign affairs, development assistance, defense, and law enforcement. So it is pretty much, it involves every sector in a given host country. So what we have is, we have 6 pillars of health security. We prevent, we detect, we respond, and we build health systems. We align norms, and we do a continuous risk assessments. So in 1969, the World Health Assembly adopted the International Health Regulations of 1969, and which later on morphed into International Health Regulation of 2005, which was signed by 196 countries in the world. So they agreed to, in the first Kampala Declaration, and which was modified in 2015 by the Seoul Declaration, to combat global pandemics by improving detection ability, assessment ability, reporting and response capabilities of countries. So, this is what we call the International Health Regulation Monitoring and Evaluation Framework. So whenever epidemic starts, before an epidemic starts, a country has to do what we call voluntary external evaluation, this one. And they do that, and they plan after they assess what the overall health system of that country is capable of. Then after that, after they plan it, they call it the National Public Health Security Plan. After they plan it, they would do annual states parties self-assessment, and from time to time, they do simulation exercises. And after the epidemics are controlled or responded after, they would do after-action reviews of how the infection was controlled. So the global health security has 19 action packages. So they are classified into 3 groups, but I will present here the most important ones. So the 3 classifications are under prevention, detection, and response. The prevention package, for example, has the antimicrobial resistance action package, the zoonotic disease action package, the biosafety and biosecurity action package, and the immunization action package. Under the detection, this is about diagnostics like a lab. So we have the lab system action package. We have a real-time surveillance action package, a reporting action package, and a workforce development action package. And under the response, we have the emergency operations centers action package, and we have the linking public health with law and multi-sectoral rapid response action groups. And we have medical countermeasures and personnel deployment action package. So these are very important action packages that countries use for combating pandemics. So the current global status is not that rosy. So under the prevention area, the global, there is an organization called the Global Health Index, Global Health Security Index. So each year they would review the performance of the countries around the world. So the global average for prevention is 28.4 out of 100. So making the lowest scoring category within the Global Health Security Index. 113 countries show little or no attention to zoonotic diseases within national planning, surveillance, or reporting for diseases. Under the detection and reporting, only 37% of the countries have made a public commitment to share surveillance data, and only 5, Brunei, Indonesia, Malaysia, Philippines, and Singapore made commitments to share data specifically for COVID-19, for example. Under the rapid response category, only 58% countries scored below average for rapid response to and mitigation of spread of an epidemic. Only 69 countries have an overarching national public health emergency response plan in place that addresses planning for multiple communicable diseases with epidemic and pandemic potential. So this is really disappointing. So if a country doesn't have what we call the NAPs, then this means that country is really wide open for incoming new epidemics and, of course, a very high death toll. So when we look at the health system, we have only 73 countries scoring in the bottom tier. So their health system development is very poor. 69 countries have insufficient capacity at health clinics, hospitals, and community centers. 91% of the countries do not have a plan, a program, or a guideline in place for dispensing medical countermeasures, such as vaccines and antiviral drugs for national use during a public health emergency. So again, the commitments to improve national capacity and financing in global north, still it is very low. Many countries have not submitted their IHR reports, which should be submitted every year. When we see the risk environment, 114 countries demonstrate a moderate to a very high threat of international disputes or tensions that would have a negative effect on daily operations. Next slide, please. So I want to emphasize, as P2P, we are present in Ethiopia for now, but our main target is to work in the Greater Horn of Africa, in the 10 countries. So now the US government has what they call the localization agenda, meaning all programs should be implemented by local organizations that are registered in those host countries. So I want you to see what this localization agenda looks like. We have the pillar approach, which is essential in response coordination, such as case management, logistics, contact tracing, risk communication, and community engagement. And we have to address, when we train the local responders, we have to address everything like response strategies, including the mode of transmission of the disease pathogen, the corresponding mitigation and containment strategies, and the availability of an effective vaccine. So factors that influence outbreak response, this is really known to you. I just want to quickly go through it. The number of people affected, the case fatality ratio, the disease-specific mitigation and prevention measures, and the complexity of diagnosis, treatment of the disease, and vaccine availability, the rate at which the disease transmits, transmissibility or the R-naught, transmission pathways, and level of risk and of the outbreak spreading across the international borders, whether the disease is notifiable under international health regulations, thereby bringing an international dimension to the report, to the response. So as the national government or the MOH level of capacity to respond, the following factors really determine the level of response. First, the existence or absence of a dedicated emergency operations center, which is very important when managing global health security operations. The second is the existence or absence of National Disaster Management Authority, the existence or absence of functioning National Incident Management System, the existing level of collaboration between the national, the regional, and the local stakeholders, whether the area affected by the outbreak is under national government control, if it is in a crisis situation, whether there is a previous experience in responding to outbreaks, and the strength and resilience of the health system, primary health care systems, if they are already underfunded, understaffed, or experiencing humanitarian crisis, may not be able to rapidly detect and respond to outbreaks. And there are some external dimensions to this level. The level of international threat of outbreak spreading to neighboring countries, and whether or not WHO has declared the outbreak as a public health emergency of international concern. The level of media and foreign government interest in responding to and containing the outbreak, and the presence of international actors, and presence or absence of an existing humanitarian response. So what we concentrate is we have two general conditions. The first one is a peaceful condition where all the institutions are functional. And then we have the crisis situations. In crisis situations, again, we have a partially functional institution or a completely non-functional institutions, like in Gaza, Yemen, or North Sudan, for that matter. In the case of Ethiopia, for example, we have a partially functioning health system. So in these situations, we have to kind of design the response mechanism in order to have an effective outbreak response. So the humanitarian emergency relief system looks like this. So for food security, we have World Food Program, FAO. For health, we have WHO. For logistics, WFP. For nutrition, we have UNICEF and so on. For shelter, International Federation of Red Cross and UNHCR and so on. So these are the actors which prevent, mitigate, prepare, address the disaster and respond and so on. So whenever a disaster starts, this would be the cascade of event. So one of these organizations, especially in the health side, that cluster, the humanitarian cluster, will closely work with World Health Organization, and the World Health Organization works with National MOH and the Emergency Operations Center Task Force. And this one will also work with the disaster agency, police and military, and under the EOC, we have the different implementing partners like P2P or other NGOs like Save the Children and so on. So this is the overall structure of a humanitarian response in a given country, in any country in the world, as far as health is concerned. So we want to pitch in.
1 minute. 1 minute.
Okay. So I only got 1 minute. So what I want to pass on here is we want to work into this global health security arena by closely working with bilateral and multilateral agencies like USAID, CDC, Bureau of the Humanitarian Assistance, and UN organizations. So P2P can really mobilize. We have around 5,000 members around the world, so we can mobilize all kinds of expertise, not only in the global health security agenda, but in all related fields that can be, that can be implemented in developing countries. So I just want to stop here. I don't have time. So if you have questions, I'll respond to your questions. Thank you.
Thank you, Dr. Zelalem. Appreciate that. Is Dr. Igbe, is she online? No? Dr. Igbe is an accomplished physician and also management consultant over 30 years of global experience in healthcare strategy, policy investment. She is a founding partner of Adanach Group and global health strategy firm focused on transforming healthcare system through the innovation, solution of public and private sector clients. She has worked with a prominent organizations such as the World Bank, International Finance Corporation, and Booz Allen Humanitarian Project in Africa, Asia, and Middle East, and also in the United States. Her expertise spans hospital restructuring, health policy, dialogue, and private and healthcare investment with focusing in emerging markets. Dr. Osifo is a board member of the Medicus UK and member of the Healthcare Advice Council of British International Investment. She has co-organized the first mHealth conference in Africa and series of linking international venture capital to teach startup in Africa. So as you see, Dr. Igbe has an extensive experience in diaspora work. So in this saying that, and I would like to invite Dr. Igbe to say a few words. Okay. And then the question from the floor will come on.
Okay, thank you so much. And thank you so much for the wonderful introduction. I almost did not recognize myself. We also forgot to say that I had worked with, that Anadak had worked with P2P. Hear me? That Anadak had worked with P2P during COVID, and we had done some of the very first sort of Pan-African training and sharing of information on COVID across Africa, but including Asia and Italy, at the very start of COVID. So it was a wonderful experience to work with P2P on that, and also co-author the chapter on the triangular diaspora. So as was mentioned, I now I'm partner in a firm, and we believe very much in sort of leveraging the use of diaspora. We're a US-based company, we're an American company, and it's very interesting to have people that understand the continent, but also understand the US environment in particular, and see how we can leverage that to move the continent forward, in many ways. And I will sort of describe our engagement with the diaspora in both a sort of capacity, but also in terms of sort of on the financial perspective in healthcare. And one of the things, my first exposure to working with the diaspora was trying to set up an African Institute of Science and Technology. And then we're going through sort of diaspora with mathematics and engineering backgrounds in the US and in Europe. At that time, I was in the World Bank, and it was amazing the amount of capacity you had. And so when we started our company, this was something we decided that was really important to us. So we have about 200 consultants that work with us, and at least half of them are members of the diaspora, different countries across the continent. Recently, last year, we became grantees for 2 USDA contracts The USDA is the US Trade and Development Agency. And basically, they gave us grants to work in two countries, in Senegal and in Nigeria. And in both countries, for people who may be aware, if you work with the USDA, 80% of the money has to go to US people. So either US people who are US citizens or green card holders. I mean, it's very strict, and this has been sort of it's in the law. I mean, this has been approved by Congress. And so one of the things that we thought that was really important was that really making sure we engage, with, if you have 80% going, towards the US, we needed to make sure that we engage with people who knew the environment, the countries that we were working in, and who had sort of particular sort of interest and sort of language. And so in both countries, in one of the countries, in Senegal, we're working with the government, and a significant number of consultants or the people who are working with us or bringing expertise are basically US citizens of African origin, sort of various countries. But because it's a Senegal, language is also extremely important. So we're working with lots of folks of Francophone African origin. And then in the other components, in the country we're working with, which is Nigeria, we also have a significant number of diaspora. And one of the reasons why I thought this was important to share is that, and I know the speaker earlier talked about working with the Horn of Africa and sort of localization. So definitely there is a focus on localization. I think by USID and some of the US agencies, some of the other US agencies that are basically focusing on bringing sort of commerce or, sort of growing the US commerce is, how can you use this sort of strategically to make sure that you do good work, because you have people that understand the countries, understand the history or the social issues around the countries, which is sort of extremely key to any successful project. And as anybody who works in development knows, half or 60% of projects fail, often because people don't understand the dynamics, either the health dynamics or the politics of the health dynamics or the issues in the country. And, sometimes, language issues are really important. People say, if you speak in my language, you're speaking to my heart. And so for us, in the work we do and any of the work I do, I think it's really important that, we have people that understand both parts, both sides, sort of having a significant position in that space. And when you look at other parts of the world, I mean, in Asia, for example, you see a lot of different Asian Americans sort of leveraging their resources on both ends. And this is something which I think in Africa or many of the African countries are just coming of age, and I think it's something that we need to be very deliberate and sort of strategic about, Of course, you must never break the US law, and we don't. We only work with, US citizens or green card holders, but within the context, and often sometimes the best people for the job, they may not be diaspora. That's a different issue. Sometimes we're doing infrastructure, health architecture. Very few people have those skills, but then you work with people. But there are skills that really the best people, like if you're trying to change sort of clinical practice, you're trying to change sort of health sector reform, you need people that really understand the system, that really know the right people to talk to, who may not be able to be obvious. And in that context, often the diaspora person may be the right person for the job. And I really think that as we work with US projects and as for us on the call who are Americans, I know P2P is wider than the US. For those of us who are Americans, I really encourage people, in any projects you do, to figure out how you can leverage our wider network. But thank you so much.
Thank you so much, Dr. Igbe. I know you have time constraints. If there is any question from the audience for Dr. Igbe before she leaves. Thank you very much, Dr. Igbe. We're looking forward to work with you ahead of time with people to people. Thank you.
Thank you very much. And hopefully not another pandemic. Well, thank you. I know the person before talked about global history. Well, look forward to working with you during peacetime. Thank you.
We'll meet you in Kigali then. Thank you.
Okay then. Bye.
All right. Bye-bye. I think the other presenter or panelists, as I said earlier, they are conflict of interest, so they couldn't be here today. Thank you.